Good afternoon, and welcome to the Johns Hopkins 30-minute COVID-19 briefing, where we provide live insights from the experts who lead our work at the Johns Hopkins Coronavirus Resource Center. For the next half hour, we'll focus on what you need to know right now about the COVID-19 pandemic and public health responses. As a reminder, we will offer these 30-minute briefings regularly on Fridays. I'm Dr. Lainie Rutkow, a professor at the Johns Hopkins Bloomberg School of Public Health, and I'm part of the leadership team for the Johns Hopkins Coronavirus Resource Center. We'll be providing answers in real time, so please do submit your questions in the box at the bottom of your screen. Today, I'm joined by two guests. First, Dr. Brian Garibaldi, who's the director of the Johns Hopkins Biocontainment Unit and an associate professor at the Johns Hopkins School of Medicine. Brian will give us an update about the treatment of COVID patients. Then we'll hear from Dr. Bill Moss, who's the executive director of the Johns Hopkins International Vaccine Access Center and a professor at the Johns Hopkins Bloomberg School of Public Health. Bill will give an update on COVID vaccines. I'm now going to turn to each of our speakers for a brief overview. Brian, first to you. Over the last 2 weeks or so, we've heard increasing optimism about the decline of the Omicron surge, and mask mandates are being rolled back throughout the United States. How does all of that compare to what you're seeing in the hospital?
Well, thanks, Lenny. Well, wow, what a difference 2 weeks can make. Over the last week, cases are down 40%, hospitalizations are down 20%. And what we're seeing across the country, we're definitely seeing here in Maryland. The number of patients who've been hospitalized with COVID has markedly declined. We peaked at about 3,600 patients hospitalized across the state. We're now bordering on about 1,000. And we've returned at our health system, most of the units that had to be converted into COVID special biomode units have gone back to normal functioning. I think where we still continue to see issues is with ICU capacity. So while many of the critically ill COVID patients are no longer in a window where they're infectious with COVID and require isolation, a lot of them still require many days to weeks on ventilators and will have prolonged recovery time. And so we're seeing a really large demand for ICU beds for critically ill patients, not just with COVID, but with other diseases who really do require that ICU level monitoring, either for their illness or for elective or urgent surgical procedures. But that load is starting to get better every day. I'm actually on a rotation right now where it was created for ICU doctors to take care of COVID patients outside of traditional ICUs. And thankfully this week, I actually have been seeing other ICU patients, but no COVID patients. So that's been a huge change for us. I think another thing that's changed is our ability to get patients who have outpatient symptomatic COVID access to therapies for COVID. So we have more widespread use of Sotrovimab, which is one of the monoclonal antibodies. It's the only one right now that's effective against the Omicron variant. We're able to get Evusheld, which is another monoclonal antibody, to people who haven't been able to mount an immune response to the vaccine to try to protect them from COVID. Some of the oral therapies, particularly Paxlovid and Molnupiravir, are now available in a wider number of pharmacies for patients who are at high risk to progress to severe COVID. And we're even now able to give Remdesivir as an IV infusion for outpatients over 3 days. And I think all of these changes, coupled with that decrease in community transmission, has really led to some of the improvements we've seen in the hospital. We still have seen a slow rise in the number of people who are dying from COVID, and that really is just a lagging indicator of people who were sick, several weeks ago, who unfortunately progressed to require hospitalization and then unfortunately die. But the pace of that increase is declining. So I think we're hopefully going to start seeing mortality start to decline on a week-to-week basis as well. I would still continue to urge people who have not yet been vaccinated. There's still Omicron transmission in the community. And so if you're eligible to get a vaccine, please do. And if you're eligible to get a booster, you should go ahead and do that too, because we know the boosters protect not just against symptomatic disease, but they really provide outstanding protection against the risk of getting severely ill or dying from COVID. So please, if you haven't been vaccinated or if you're eligible for that booster, go ahead and do that. I know there's going to be a lot of interest this week in terms of mask mandates. I think it's great that we're able to have this discussion right now and start talking about when would be the appropriate time to lift these mask mandates in some places. I'm a little worried that we've seen this movie before, and that we might be moving a little bit quickly in terms of relaxing some of those mitigation efforts in response to the thankful decrease in community transmission. But we're still in the middle of winter. People are gathering indoors frequently. And so I think removing some of those mask mandates makes me a little bit nervous. I think we might be a little bit too early to be doing that, especially when you look at the number of individuals in our country who are eligible to be vaccinated but still haven't been vaccinated. And you look at the number of people who are at risk to not mount a response to the vaccine and could be at risk for severe disease or death. Um, I think there are certainly different circumstances to think about. Schools are probably the most controversial. There's obviously great benefit for children to be able to interact and learn with the additional cues that you get when you're not wearing a mask. But less than 50% of eligible kids 5 to 12 are vaccinated right now, and so I do worry with um, being in the middle of winter, what's going to happen as we start to relax those mandates. I do think we are approaching a point at which individuals, really need to continue to think about their own personal risk and the risk of those around them to be able to make decisions about mask wearing. So, even if a mask mandate goes away, if you have access to a mask and it's a high quality mask that fits you well and you'd like to wear it, please wear it. I'm going to continue to wear a mask indoors for the foreseeable future. A lot of that is driven by my own situation as a healthcare worker, where I don't want to get sick and miss a shift when my colleagues have been working really, really hard for the last 2 years. And I want to continue to be able to do my part in that effort. But I think, I hope as mask mandates go away, people will be very receptive and supportive of individuals who still choose to wear a mask, because you can never really understand what someone's circumstances are. And there are situations indoors right now where many people should continue to wear masks.
Thanks so much, Brian. Still lots to think about in this shifting terrain. Before I turn to Bill, I do want to remind our audience, please submit questions for our experts in the box that you see at the bottom of your screen. I'm keeping an eye, and I do see your questions coming in, and after Bill, we will turn to Q&A. So, Bill, as this Omicron surge declines, what should we be thinking about in terms of vaccines? In the US, it seems like a lot of the focus is on boosters. What about the rest of the world?
Yes, thanks, Lainie. And as Brian just outlined, there is reason to have cautious optimism at this point, with cases going down, hospitalizations going down. As Brian pointed out, we're still seeing high numbers of deaths, and the ICUs are still somewhat strained. So what I'm going to do, Lainie, is kind of lay out for the United States, and then I'll come back to the global picture, a best case scenario and a worst case scenario. So I think in the best case scenario, we're going to, we will continue to see case counts decline, see declines in hospitalizations and deaths. As Brian said, that's a lagging indicator. But we're going to continue to see new variants of this virus. But in the best case scenario, those new variants, this virus is going to mutate, will not escape the immunity that we've built up through vaccination and through infection. So we will, in the best case scenario, really move to a new normal post COVID-19 life, with lessening of restrictions, masks and social distancing, as is already beginning to happen. I completely agree with Brian that hopefully we've created some new norms around wearing masks for individuals who are sick or who are vulnerable to really any respiratory virus infection. With regard to vaccines, a couple things I foresee, in this best case scenario. I think we'll see a slow increase in vaccine coverage, but I don't expect we're going to see any dramatic shifts. If we look at the rate of increase in vaccine coverage, it's really slowed. Those curves have really plateaued, and we see marked differences in vaccine coverage by age groups. We look at that 65 to 74-year-old age group. 95% of people in that age category have received one dose. 91% two doses. Very tight, small interval between those two. That's fantastic. That's really high vaccine coverage. But as we go down into lower age groups, we see much lower coverage, and we see that gap between 1 and 2 doses kind of increasing. So for example, from 25 to 39, 78% 1 dose, 65% 2 doses. Down to adolescents, 67% 1 dose, 57% 2 doses. What's been of concern to me is the 5 to 11-year-old age group. Only about a third have received 1 dose, and about a quarter are fully vaccinated. So still, despite the several months of having an authorized vaccine for 5 to 11-year-olds, coverage remains pretty low. In terms of boosters, only fewer than half of individuals who are fully vaccinated have received a booster, just about 43%. And I think there are a number of reasons for that. But these are obviously people who are not against the vaccines. They've received 2 doses of an mRNA vaccine or a single dose of J&J. But I think their risk benefit ratio or calculus has changed. I recognize there's been some confusion around changing recommendations, but I think there's also been less concern about Omicron. But we know, as what Brian was saying, that Omicron has really stressed our healthcare systems and very high death rates, and then perhaps some increased concerns about side effects with a 3rd dose that may take people out of work for a couple days. But so we still are not at where we should be with either the primary series of vaccination or with a booster dose. So going forward, I see expanded eligibility. Lainie, the exciting thing that's coming up is the FDA's Vaccine Advisory Committee is meeting next Tuesday, February 15th. To discuss the Pfizer-BioNTech vaccine for those 6 months to 5 years of age. A lot of controversy around this. As we know from Pfizer reported, preliminary results from their trial suggested that this lower dose of the vaccine had reduced immunogenicity, lower antibody levels in the 2-year to 5-year-old age group. What they decided to do, as we've talked about before here, add a 3rd dose of the vaccine, but they're going ahead with this FDA review without waiting for the full data on that 3rd dose. And that's created some controversy. That's not really been done before, where the FDA has reviewed for authorization a product without having the full clinical trial data. So I think we're going to see a very lively debate on this next Tuesday. We'll have to see how that plays out. It really raises the issue of these tensions of making decisions with limited data in the face of a pandemic, and it's tricky business. But I expect to see arguments on both sides of this at the FDA Advisory Committee meeting next week. One outcome, kind of compromise outcome, could potentially be that it's recommended for those children at high risk, and maybe not for all children 6 months to 5 years of age, but those with underlying conditions that place them at high risk. We've also heard, Lainie, that from the CDC, that the US government is preparing to have 10 million doses of this vaccine. Remember, this is a smaller dose, so it's a different kind of product in that way. Now, there are about 18 million children in this 6 month to 5 year age group in the United States. 10 billion doses will get you about coverage for about 5 million children on 2 doses, but only about 3.3 million going with the 3-dose plan. Another thing with expanded eligibility is we may see booster doses authorized for children 5 to 11 years of age. So one thing going forward is this expanded eligibility. We're going to have more data on vaccine effectiveness and safety going forward. That'll give us more precise estimates of rare adverse events. And I think a key piece of data that we need is the duration of protection against different outcomes from these vaccines going forward, because that information is going to be really critical in driving decisions about additional booster doses. We may also see some tinkering with the vaccination schedule, particularly the intervals between doses. We didn't have time in the midst of the pandemic to really optimize what is the best interval between the 1st and 2nd dose, and between a 2nd and a 3rd dose of the vaccine. With regard to additional booster doses, right now in the United States, 4 doses are recommended for individuals who are moderately to severely immunocompromised. That's a 3-dose primary series plus a booster dose. There are some countries, such as Israel, that have expanded the eligibility for a 4th dose. For example, individuals 60 years and older. We're not at that place yet in the United States, and we're going to have to see how transmission and vaccine effectiveness play out going forward. It's really hard to say what booster doses are going to look like, but it's possible we could have an annual booster dose. But that's going to depend critically on the duration of protection, particularly against severe disease. Going forward, we may see new vaccines, an Omicron-specific vaccine, although that's going to be kind of late in terms of the Omicron surge. It's not clear how much of a role that will play. There may be some people for whom that's important. As we've talked before, Lainie, I think we will see new vaccines, such as protein-based vaccines. There's been some excitement about mucosal vaccines that are administered intranasally that may provide more protection against infection. And then ideally, a pan-coronavirus vaccine. I think one of the lessons that I took away from the Omicron surge is that despite the ability with the mRNA technology to kind of pivot and switch out that genetic recipe for the spike protein, the process is still too slow in the face of a readily transmissible variant. And as I alluded to before, an Omicron-specific vaccine really coming at the tail end of the surge. We're going to continue to see misinformation and disinformation. We're going to continue to see battles over mandates, as we're already witnessing now. That's the best case scenario, Lainie. Worst case scenario, we have a new variant that's highly transmissible, escapes immunity, perhaps causes a more severe disease. And then I think it's going to really come down to what do we tolerate as a society. We cannot have a situation where our hospitals are overcrowded, our ICUs are overcrowded, thousands of deaths a day. I always kind of remind myself that just under 3,000 people died in 9/11. And we are tolerating 2,000, 2,500 deaths per day over the past several months. And so we have more people die in 2 days than died in 9/11 over and over and over and over again. And yet that seems to have become normalized. If we see a new variant that escapes immunity, we have a couple strategies. We can try our booster doses with our current vaccine, see if that increase in neutralizing antibody levels gets us to a place where we have protection. Again, variant-specific vaccines, but the process would have to be speeded up for that. And then hopefully at some point a pan-coronavirus vaccine, but I still think that's a way away, some time away. In terms of the global situation, Lainie, just to wrap up, about 2/3 of the world's population has received 1 dose of a COVID-19 vaccine, so that's great. But we still have these great global inequities, as we've talked about before. Only about 15% of the population in Africa has received 1 dose. And so SARS-CoV-2 is going to continue to circulate globally. It's going to continue to mutate. Hopefully we won't see a new variant that really escapes our immunity, but that's yet to be seen. We're going to continue to see inequities in vaccine coverage. I think the supply bottleneck will improve, and I hope we see more vaccine manufacturing in low and middle income countries, but these countries are still going to face challenges in getting the vaccines to those who need them and ensuring that there's actual demand for these vaccines in the face, particularly of vaccine hesitancy, misinformation, and disinformation. And then lastly, the WHO has been reviewing data on booster doses and recognized that there may be a role in some circumstances to provide that increased protection against Omicron or perhaps a future variant, but that the priority right now is really given to preventing severe disease and sustaining health systems and getting first doses and second doses into people.
Thanks, Bill. Wow, that was an emotional roller coaster of an update. I see we have lots of questions coming in, so I'm now going to move over to those. And Brian, the first question I'm going to send to you, and it concerns those that have had COVID more than once. So as a clinician, are you able to tell that when you're treating a patient? Is that something that's tracked? And do you see differences among those that have been infected more than once?
Yeah, so obviously the way to do that when you're seeing an individual person is just to ask. We always ask about vaccine status. We always ask about prior COVID infections or suspected COVID infections. On the hospital side of things, it is true that having had COVID once does provide some protection against severe disease. And the people who have probably the best protection against severe disease and death are people who had COVID and also got vaccinated. So even if you've had COVID before, I still think it makes a lot of sense to get vaccinated to really boost that protection against severe disease and death. We unfortunately do see people who get reinfected, but by and large, we've been seeing, um, the people who are coming into the hospital who are really, really sick are people who are either unvaccinated and never had COVID before, or they're people who have some immune system condition where they're just not mounting an appropriate response and they're still at very high risk of severe disease or death. But in general, we have not seen a lot of people getting infected 2 or 3 times, requiring hospitalization for severe COVID or even death.
Thanks, Brian. Bill, I have a vocabulary question for you. And in the last 2 years, you have taught me a lot of new words. So this one concerns a word that we're beginning to hear a lot in the news, and that is endemic. Can you explain what that means?
Yes, Lainie, this is a word we use the terms endemic and epidemic very frequently in epidemiology and infectious disease epidemiology in particular. Unfortunately, there's no kind of precise definition of these, and I think that's created some confusion and ambiguity. But basically, an epidemic is when the number of cases, the incidence of a disease, rises above the norm. And that can be defined in different ways, whereas an endemic disease just refers to a disease that that has kind of continual transmission. It can go up and down like influenza or RSV. And so there can be kind of increases in the number of cases and decreases in cases. But there's no precise distinction between an epidemic or a pandemic and an endemic situation. But it is an important term because a lot of us are thinking about, what is the future going to look like with SARS-CoV-2, and what will that endemic transmission look like? But there's a lot of heterogeneity in what that can be. It can be kind of low-level transmission, or we could have periodic outbreaks.
Thanks, Bill. I'm going to make a prediction because this is the first time that I've raised that term in one of these briefings. I will predict it is not the last.
Yes.
Hey, Brian, question for you. 2 years in, if you think about lessons learned or changes that you've seen, how do you think that this pandemic is likely to affect ICUs or emergency departments of hospitals as we move forward?
Well, I think we really need to look at the way that we're able to rapidly scale up capacity, and we need to make sure that we don't just completely go back to normal business operations. I think we need to build in the ability to have more physical spaces that are able to take care of patients who might need special types of isolation, particularly for airborne diseases. And we've been able to do that. We've been able to scale up space in many areas to be able to handle that capacity. The biggest challenge that we still haven't solved and that we're going to need to solve is how do we be more creative and flexible in our staffing models? How do we flex up staff to be able to take care of patients who might need higher acuity than the hospital is prepared to deal with? And when I say that, it's not just an individual health system issue. It's the ability to use data on the ground to move services and individuals across health systems, but also across geographic and state boundaries to be able to meet the demands where they might be greatest. And we've had some flexibility with telemedicine, for example, where we've been able to suspend some of the regulations about practicing across state lines to be able to do telemedicine visits for people who can't travel. But I think we also need to look at how we can be more flexible to get people with the skill sets we need, nurses, doctors, technicians, pharmacists, respiratory therapists, you name it. We need to be able to get them to where the demand and the need is. And that's going to require, I think, more collaboration across health systems and across state governments than we've had in the past. And I think there's a movement to do that. There's great interest in the Department of Homeland Security and the Assistant Secretary for Preparedness and Response to really start thinking about responses to infectious disease events, much like we think of disaster responses, much like we can mobilize, teams from all across the country to go deal with natural disasters or wildfires or hurricanes. We need to start thinking about how we build that same national system for pandemic preparedness. And obviously, a big component of that is going to be the staffing and the materials and the supplies. But another really important component of that is the surveillance needed to understand where the next threat is likely coming from, and to be as proactive about meeting that need early. And I think that may be one of the biggest lessons that we learned in this current pandemic is we were flying blind for months because of our initial missteps in getting rapid testing available throughout the country. And I think we've never really caught up to that testing need, as we've talked about on this show or in this program before. So I think those are the big areas we need to work on. Better communication and collaboration across state agencies and federal government, better surveillance testing, and being much better at boosting up staffing needs to really respond to these threats as they emerge.
Thanks, Brian. And I'm going to send one more question to you, and it'll probably be the last word for this briefing. Question about any developments relative to the so-called long hauler or long COVID patients. What are you seeing? What are new developments in the last couple of weeks or months?
Yeah, probably the biggest development that's come out in the last couple of days even is the recognition that people who had COVID previously in the year following their infection are much more likely to have a cardiovascular event, either a heart attack or a stroke. And that risk seems to be, directly associated with the severity of your COVID illness. And we still don't understand the mechanism behind that, but certainly that initial infectious insult followed by that inflammation probably puts people at risk for cardiovascular events, having sort of reactive endothelium, and the likelihood that they might form a blood clot or have some adverse event like a stroke or a heart attack. I think that's probably the biggest thing that we're following now and urgently trying to understand. And we honestly haven't made much headway in understanding some of those other symptoms that we've talked about, like the profound fatigue and the brain fog and some of the long-term neurologic consequences that we see from long COVID. And I think it's going to be years to unpack this and to really understand what all the different subphenotypes are and how much of it is the virus itself, how much of it is the immune response, how much of it is the individual the person who was infected, their own response to that infection. So I think we're going to be learning about this for years.
Thanks so much, Brian. And with that, I'm going to wrap up since we're just about at 12:30. I'd like to thank Brian Garibaldi and Bill Moss for joining me today and give a big thank you to everyone who joined us, and especially to those who submitted questions for our experts to answer. This briefing will be archived and available on coronavirus.jhu.edu. As a reminder, we will continue to offer these 30-minute briefings regularly on Fridays this year. Our next briefing will be on Friday, February 25th at 12 p.m. I'll look forward to seeing you then, and until then, thanks and stay safe.